Welcome to today's clinical masterclass. We are diving into a rigorous, profoundly data-driven look at one of the absolute most formidable frontiers in modern cardiothoracic surgery. This explainer is specifically designed for you, the specialists, the professors and attending physicians who are actively pushing the boundaries of what is clinically possible. We're going to take a really deep, comprehensive dive into the highly complex, unforgiving procedure that is simultaneous heart-lung transplantation. Hello, specialists. Thank you for your hard work today, performing simultaneous heart and lung transplant surgeries and administering anesthesia. Starting today, I will review simultaneous heart and lung transplants, which are among the most difficult surgeries, in two parts. 専門医の皆様、こんにちは。本日は同時心肺移植手術の実施と麻酔処置にご尽力いただきありがとうございました。本日より最も難易度の高い手術の一つである同時心肺移植手術について2回に分けて解説いたします。Alright, let's jump straight into our agenda for today. We'll be moving through 6 key areas. First, the history and evolving indications. Second, donor allocation and advanced preservation techniques. Third, we'll break down advanced surgical techniques. Fourth, intraoperative anesthesia management. Fifth, we'll examine contemporary outcomes and survival data. And finally, we'll cover special considerations for cystic fibrosis patients. Section 1. History and evolving indications. To truly appreciate where we are today, we have to look back at the genesis of this procedure. The very first successful simultaneous heart-lung transplantation, or HLTx, traces back to 1981 at Stanford University, pioneered by Dr. Bruce Reitz. Now, it's absolutely crucial to remember that this monumental surgical achievement didn't happen in a vacuum. It was fundamentally enabled by the pharmacological breakthrough of cyclosporin A. Without that targeted immunosuppression, clinical application would have remained completely out of reach. Since that watershed moment, we've seen approximately 4,000 cases performed globally based on the ISHLT registry data. Interestingly, if you look at the historical timeline, we actually hit a global peak in procedure volume around 1989 to 1990. Following that, the numbers began a steady, noticeable decline. Why did that happen? Well, it was primarily driven by the rapid, parallel advancements in isolated lung transplantation, specifically bilateral or double lung transplants. As those isolated procedures became more successful, they offered a viable alternative for many patients, sparing the native heart. However, the story doesn't end there. If we look at the modern era, particularly tracking from 2014 onwards, we are witnessing a really fascinating and steady resurgence in HLTx, predominantly within the adult population. And to understand why that's happening, we need to look at how our patient selection has evolved. So let's unpack our current clinical practice, specifically regarding those evolving indications, because there has been a massive paradigm shift. Back in the early era, roughly 1982 to 1991, idiopathic pulmonary arterial hypertension, or IPAH, was by far the most common indication. But as you know, our clinical understanding of cardiopulmonary hemodynamics has become vastly more sophisticated. We now definitively know that severe right ventricular failure in the setting of IPAH can actually be completely reversed. By normalizing the pulmonary vascular resistance through a double lung transplant alone, that failing right ventricle can remarkably remodel and recover. Therefore, the modern consensus is clear. HLTx for IPAH is now strictly reserved for patients who have concomitant severe left ventricular dysfunction. Because of this strategic shift, complex congenital heart disease, or CHD, has completely taken over as the primary indication. Looking at modern waitlists, Eisenmenger syndrome now leads the pack at roughly 35%, followed by our specific subset of IPAH patients at 27%, and cystic fibrosis rounding out the top tier at about 13%. We're also seeing an uptick in acquired heart diseases. Think ischemic cardiomyopathy combined with profound secondary pulmonary hypertension. When we look at the sheer complexity of these modern indications at a single high-volume center, it becomes glaringly obvious that we are no longer dealing with straightforward pathology. The adult congenital patients presenting for HLTx today have incredibly complex anatomical and physiological derangements. We are regularly evaluating cases like Schoen's syndrome with secondary, irreversible pulmonary hypertension, or patients with transposition of the great arteries who perhaps underwent a mustard operation decades ago and now present with catastrophic systemic ventricular failure alongside pulmonary vascular disease. We might also see polysplenia syndrome. These are patients who have often endured multiple previous sternotomies, their chests are a maze of adhesions, and they are frequently highly sensitized, making cross-matching a nightmare. We also evaluate patients with systemic diseases featuring dual organ involvement.
For instance, advanced sarcoidosis with both severe cardiac infiltration and end-stage pulmonary fibrosis is a completely valid indication for the en-bloc procedure. Conversely, it is absolutely vital for our multidisciplinary selection committees to remember the contraindications. While we look at standard recipient criteria like age, ASA score, and other end organ function, a history of mantle radiation to the chest remains a really strong relative contraindication. The catastrophic risks of tissue friability, mediastinal fibrosis, and uncontrollable bleeding during the explant often make the procedure unviable.
Section 2. Donor allocation and preservation. Moving on to logistics, the allocation of a multi-organ heart-lung block is quite literally a masterclass in medical triage, and the philosophy behind it varies significantly by geographic jurisdiction. When we contrast the UNOS system in the United States with the European Eurotransplant model, distinct priorities emerge. In 2018, UNOS completely overhauled their heart allocation policy. They now place a massive emphasis on prioritizing candidates who are bridged with mechanical circulatory support, or MCS. This directly reflects the rising clinical significance and, frankly, the improved survival rates of the ECMO bridge-to-transplant pathway. We are seeing more and more of our sickest patients successfully bridged this way. Eurotransplant, on the other hand, operates slightly differently, relying on strict urgency codes like high urgency and requiring specific high-level approvals for combined organ allocations, categorizing candidates clearly into transplantable or not transplantable statuses. But regardless of which system you operate under, finding the right donor is incredibly difficult because the criteria are exceptionally stringent. We are generally looking for pristine donors under the age of 60, we mandate absolute ABO blood group identity, we meticulously evaluate the cause of brain death, lung function, and echocardiogram findings. And crucially, we require incredibly strict thoracic size matching. The donor's total lung capacity must absolutely be within 10% of the recipient's. Any greater discrepancy invites lethal thoracic size mismatches, leading to either graft compression or catastrophic pleural space complications.
So, the absolutely critical question for our field is, how do we expand this desperately small, highly restrictive donor pool? And this is where I want to spend a bit of time, because we are no longer bound by the rigid, terrifyingly short ischemic times of the past. Advanced preservation technologies are quite literally revolutionizing organ viability and aggressively expanding our geographic range for procurement. Let's talk about ex vivo normal thermic perfusion, specifically utilizing systems like the Organ Care System, or OCS. By actively perfusing the organs with warm, oxygenated blood and actually ventilating the lungs outside the body, we aren't just storing the organs, we are continuously assessing graft viability in real time. This is a staggering leap forward. In one recent landmark case, this exact technology allowed a surgical team to procure and transport donor organs from an astounding 2,200 nautical miles away. Think about what that means for a patient on the waitlist. Alongside this, we have incredible advancements in temperature-controlled preservation using devices like the Paragonix Lung Guard, and we are seeing excellent clinical outcomes utilizing 10 degrees Celsius cold static storage. By keeping the heart-lung block in optimized cold HTK or LPD solutions at exactly 10 degrees rather than the traditional cold or flush, we are mitigating cold-induced cellular injury and safely pushing total ischemic times towards the 6 to 8 hour mark for lungs and up to 5 hours for the heart. These strategies are absolute game changers, effectively erasing traditional geographic boundaries and allowing us to say yes to organs that we previously would have had to decline.
Section 3. Advanced surgical techniques. Now, let's step into the operating theater. The recipient surgery demands a level of absolute, uncompromising precision. Following a median sternotomy, we initiate cardiopulmonary bypass, and the native, failing organs are explanted en bloc. During this explant, especially in those complex radial sternotomy patients we talked about, the absolute necessity of identifying and meticulously protecting the phrenic nerves, the vagus nerves, and the recurrent laryngeal nerves cannot be overstated. Nerve injury here leads to devastating postoperative diaphragmatic and vocal cord paralysis. Once the chest is empty, the implementation sequence is highly standardized to ruthlessly minimize warm ischemic time. Step 1 is always the tracheal anastomosis. A critical, non-negotiable technique here is keeping the donor trachea as short as possible. We aim for ideally just 1, maybe 2 rings above the carina. We then wrap that anastomosis securely with surrounding donor peritracheal tissue or an intercostal muscle flap to promote neovascularization and healing. Once the airway is secure, we immediately move to the right atrial anastomosis. And finally, we complete the circuit with the aortic anastomosis.
I want to pause this surgical walkthrough right here to discuss a vital physiological concept that dictates everything we just talked about: coronary bronchial collaterals, or CBCs. These are tiny, naturally occurring vascular connections that run from the atrial branches of the coronary arteries directly into the bronchial arterial system. Here's why they matter. When an intact, en-bloc heart-lung block is implanted, these CBCs naturally and immediately restore systemic arterial blood flow to the distal donor trachea and the carina via the newly implanted heart. This elegant physiological quirk brilliantly explains why the historically high rates of catastrophic tracheal anastomotic ischemia, necrosis, and dehiscence that plagued early isolated double-lung transplants are actually incredibly rare in intact simultaneous heart-lung transplants. But this brings us to a really tricky modern surgical dilemma. To utilize those advanced machine perfusion technologies we just discussed, like the OCS, surgeons are sometimes forced to surgically separate the donor heart and lungs on the back table. They then perform essentially an en-bloc double-lung transplant followed immediately by a sequential heart transplant. Now, while this brilliant workaround solves the geographic distance problem by allowing the organs to travel in separate perfusion rigs, it physically severs those highly protective CBCs. By doing so, we are knowingly reintroducing the historical risk of airway ischemia and anastomotic complications. It is a profound clinical trade-off between maximizing the donor pool through remote procurement and optimizing airway healing, and it's a debate our surgical community is keenly aware of.
Section 4. Intraoperative anesthesia management. Shifting gears to the anesthesiologists in the room. Your management of these patients is extraordinarily high risk. You are dealing with patients whose cardiopulmonary reserves are entirely depleted. They're hanging on by a thread. The induction of anesthesia alone carries an extreme, ever-present risk of complete hemodynamic collapse. Therefore, induction strategies are heavily reliant on cardiostable agents, frequently a ketamine-based protocol, alongside immediate, highly invasive continuous monitoring. We're talking pre-induction arterial lines, pulmonary artery catheters, and the absolute necessity of ubiquitous transesophageal echocardiography, or TEE. But the true test of your skill comes hours later, weaning the patient off cardiopulmonary bypass. Think about the physiology here. The fresh, previously unstressed right ventricle of the donor heart is suddenly waking up and being exposed to the recipient's native vasculature and potentially altered pulmonary vascular resistance. To manage the immense risk of acute right heart failure during this critical volatile window, our anesthesiologists employ a highly bespoke, dynamic pharmacological cocktail. We routinely use inhaled nitric oxide and aerosolized prostacyclin, like PGE1, to aggressively dilate the pulmonary vascular bed and drop the resistance. We pair that with milrinone for dedicated right ventricular inotropy and concurrently run norepinephrine to maintain systemic vascular resistance and ensure adequate coronary perfusion pressure to that new right ventricle. It is a phenomenally delicate balancing act. Furthermore, the anesthesia team plays a paramount role in preventing primary graft dysfunction, or PGD, right from the moment of reperfusion. This involves rigorous, non-negotiable adherence to lung protective ventilation strategies the second the cross clamp comes off. You also have to employ strict, almost draconian fluid management. We must keep the newly implanted lungs as dry as possible to prevent devastating reperfusion pulmonary edema. Throughout this entire high-stakes process, continuous TEE evaluation is the compass by which the entire surgical and anesthetic team navigates. You're watching that new right ventricle like a hawk. If the TEE shows the RV beginning to dilate, distend, or fail to eject despite our pharmacological support, it guides the immediate life-saving decision to transition the patient directly onto peripheral veno-arterial ECMO. This proactive move completely offloads the struggling right heart and protects the fragile new lungs from volume overload during those critical first few postoperative days of recovery.
Section 5. Contemporary Outcomes and Survival.
So after all of this immense effort, what are the actual outcomes? Looking at the broader international data from the ISLT registry, the long-term reality of this procedure comes into sharp focus. We see early adult survival rates hovering around 71% at the 3-month mark, dipping to 63% at 1 year. Looking further out, we see 44% at 5 years and 31% at 10 years. Now, I know those numbers might initially seem a bit sobering, especially compared to some isolated organ transplants, but context here is absolutely key. The data shows us a fascinating phenomenon regarding conditional survival. If a patient manages to survive that highly precarious, complication-prone first year, their conditional median survival jumps dramatically to 10.0 years. To put that in perspective, that conditional survival is remarkably similar to a bilateral double lung transplant, which sits at about 9.7 years, though it is admittedly slightly less than the 13-year median we see for isolated heart transplants.
But please don't let the historical averages paint the whole picture, because the modern narrative is rapidly and aggressively improving. An exhaustive 40-year analysis of the SRTR database, recently published by Coe and colleagues in 2026, reveals a massive, truly celebrated drop in modern 1-year mortality. Have a look at this.
Back in the early era, from 1985 to 1996, the one-year mortality stood at a daunting 29%. However, in the most recent era analyzed, spanning 2017 to 2024, that one-year mortality rate has plummeted to an astonishing 8%. That is a staggering achievement. It is a direct testament to our massively improved intensive care protocols, our refined surgical techniques, and superior immunosuppression management. However, as clinicians, we must remain incredibly vigilant regarding severe risk factors. The data clearly shows that patients requiring preoperative ECMO have a hazard ratio for mortality of 3.82. Furthermore, the need for preoperative mechanical ventilation carries a hazard ratio of 2.01, and the use of temporary ventricular assist devices or temporary ECMO prior to surgery pushes that hazard ratio to 3.04. Other factors like donor age and ABO known identity also play a role. These patients are incredibly sick, and bridging them to transplant remains our highest wire act.
Speaking of risk factors, recipient age is also a vital, heavily scrutinized metric. A detailed analysis by Kwan and colleagues in 2022 identified that a recipient age over 58 years is, mathematically speaking, an independent risk factor for one-year mortality. However, and this is a crucial caveat for our selection committees, chronological age is not an absolute hard-stop contraindication. It requires deeply nuanced clinical judgment. For instance, if we look at data from Toyota's single-center experience published in 2014, they evaluated a cohort of 17 highly complex, notoriously high-risk patients, some of whom were actively bridged with ECMO or VADs. Despite the high-risk profile of the cohort, they still remarkably achieved an 88% survival rate at 3 months, an 81% survival rate at 1 year, and 61% at 5 years. This incredibly powerful data proves that with meticulous surgical expertise, aggressive, flawless post-operative ICU care, and a focus on physiological resilience rather than just the number on a birth certificate, those historical age barriers can sometimes be successfully overcome.
Section 6, Cystic Fibrosis Special Considerations. Finally, let's turn our attention to a very specific, highly challenging patient population, those with cystic fibrosis. CF profoundly complicates the transplant landscape due to its relentless systemic nature. As you know, these patients frequently develop secondary biliary cirrhosis due to a combination of chronic hepatic congestion from right heart failure and the fibrotic nature of the disease itself. When we are faced with a patient presenting with end-stage heart, lung, and liver failure simultaneously, we are forced to at least consider a combined heart-lung liver transplant, or HLLTx. However, the clinical data, specifically an important 2021 study by Brown et al. Reviewing 8 HLLTx cases, forces us to take a really hard pause. When we contrast the outcomes for this highly specific CF cohort with biliary cirrhosis, the 5-year survival for the massive triple-organ heart-lung-liver transplant is just 42.9%. In stark contrast, CF patients with similar pathology who underwent bilateral sequential single-lung transplants, essentially leaving the native heart and liver in place, achieved a significantly better 5-year survival of 61.9%. This data sends a very strong clinical signal. Whenever the native heart can possibly be salvaged and allowed to recover by simply replacing the lungs and lowering pulmonary pressures, avoiding the massive physiological insult of a triple organ block yields clearly superior midterm survival. Now, in those rare instances where a heart-lung block is definitively required for a patient whose native heart is actually structurally sound but is simply failing secondary to massive pulmonary pressures, we have a unique opportunity. We can sometimes perform a domino heart transplant. This involves harvesting the recipient's healthy native heart during their heart-lung transplant and immediately implanting it to save another life on the isolated cardiac waitlist. It is a brilliant, beautiful way to maximize organ utility. But despite these innovations, we absolutely must caution our patients, our referring pulmonologists, and our own multidisciplinary teams about the brutal, unforgiving realities of the waitlist. Requesting any multi-organ block drastically, sometimes fatally, increases wait times. For those CF patients who truly require a heart-lung-liver block, the registry shows an average wait time of a staggering 556 days. Compare that to an average wait of just 56 days for an isolated bilateral lung transplant. The tragic reality is that many of our patients, tethered to oxygen and an end-stage failure, simply do not have 556 days to wait. And that stark reality brings us to the very crux of our challenge as a global, collaborative transplant community. The data we've reviewed today is unequivocally clear. Simultaneous heart-lung transplantation is a definitive, life-saving therapy, and our modern outcomes, like that 8% one-year mortality rate, are rapidly improving. Yet the inescapable bottleneck remains the profound systemic scarcity of suitable donor organs. So I want to leave you, the specialists leading this field, with a final provocative thought. How can we, operating in our respective high-volume centers, further refine and optimize our candidate selection criteria to ensure the best utility of every organ? And perhaps even more importantly, how aggressively can we as a specialty leverage these incredible new remote normothermic perfusion devices and advanced cold static preservation technologies? Because if we can completely eradicate those traditional geographic boundaries, we just might overcome this organ shortage. The tools to retrieve organs from thousands of miles away are quite literally now in our hands. It's up to us to use them. Thank you so much for your tireless, incredible dedication to this demanding field and for joining me today for this clinical explainer.